Now then, the predisposing factors, etiological factors, are neuropathy, infection and ischemia, which Mike has already alluded to. Additional factors that are coming through our doors on a regular basis that cause soft tissue damage are deformity, ill-fitting footwear and trauma from foreign bodies especially. Now, it's by addressing these etiological factors that we can achieve healing. Every new patient that comes through the foot clinic, we are categorising them using the simple staging system. And then by doing so, we take a full history from the patient, we take bloods to analyse their renal and their inflammatory markers. We always assess both feet, their footwear, presence of ulcers, possible causes, and looking for signs and symptoms of infection. Some patients may also have Charcot osteoarthropathy, in which case we will be doing x-rays and foot temperatures. Now, the infection targets that we need to be accurate with antibiotic prescription, therefore we need to take deep wound swabs and send tissue samples if we can for microbiology. And it is by managing all of these above that we get good outcomes, and we follow patients up regularly in the foot clinic until we achieve stage 2 foot, such as this one. This is a gentleman who would come on a monthly basis. You can see that he's got callus. The callus is debrided. He's offered footwear and insoles to reduce the risk of future ulceration. In the next 3 slides, I'm going to show you some examples of stage 4 feet, all with neuropathy. And this gentleman's cause of ulcer was deformity. This one was caused by ill-fitting footwear, and this one was caused by a nail penetrating the foot. All 3 are examples of infection. These wounds all need to be debrided. They all need to have antibiotics, and they all need to have regular follow-up to maintain the integrity and to monitor for signs of deterioration and to ensure that the healing process is occurring. All 3 examples were given these temporary footwear with Velcro straps so that we can accommodate pressure areas and reduce those pressure areas. You can see it's soft, and the Velcro straps allow the shoe to expand in size should it be necessary. Now, you could be forgiven for thinking that this is lymphangitis on the left. It is, in fact, a young gentleman with type 1 diabetes who has critical ischemia. He was admitted on that same day that he presented with his foot. He had a distal bypass, and you can see that the colour is already restored to the toes, and the soft tissue damage is already improving. A good outcome for this young gentleman. Now, to observe how we're doing, we have this 3-dimensional wound technology, and you can see from the picture on the top left, there's a wound there. We've drawn round it with a mouse, and it gets uploaded onto our electronic patient record. And on the graph on the bottom left-hand corner, you can see that the area reduction is going down in size until there's full healing. However, on the right-hand side, you can see there's a couple of blips where the size has gone up, where we may need to have changed the management plan to finally achieve healing. And I'd like to share with you the fact that we use the total contact cast regularly in the foot clinic. It is considered to be the gold standard to offload neuropathic ulcers, you can see from the left, arch fractures you can see in the middle, and for the acute Charcot osteoarthropathy. And for this talk, I will concentrate on soft tissue deficits, such as this one. It's a heel ulcer. The patient underwent a debridement. It was then thought that we would use topical negative wound therapy, as you can see from the picture on the left side. There is a sponge applied to the wound. It is attached by an adhesive taping. It's attached then by a pump which delivers 125 millimetres of mercury. When the wound comes to the surface, as you can see from the right-hand picture, we have offloaded further in a total contact cast and the patient is healing well. Other examples of heel offloading is this boot that is used for when patients are in bed. It offloads the heel. It's almost like a big sleeping bag that wraps around the foot to offload the heel. It's not for walking, it's just for used in bed. And on the right-hand side, we've got this other boot called a Praffle, which is a pressure-relieving ankle-foot orthosis, which also offloads the heel, but the patient can mobilise safely in. And as an example of new collaboration and new technology, from this picture on the left-hand side, there's a non-healing ulcers, and the reason that it's non-healing is because the patient has an active osteomyelitis. You can see the abnormality in the X-ray and on the MRI scan, and it's with collaborating with our orthopaedic colleagues that we can learn to carry out bone biopsies in the outpatient department, send the bone to the microbiology lab so that we can target more accurately the antibiotics that this patient requires. An additional new technology that we've been using recently for apical and dorsal ulcers are flexitenotomies that can be carried out easily using these needles for good results to heal those ulcers. And finally, I'd like to say that most soft tissue injuries can be treated successfully by using the simple staging system. It aids foot categorization and directs management of soft tissue injuries for successful outcomes. Thank you very much.